Okay, so thank you very much for having me on this very, very interesting and very valuable to me symposium. I appreciate being invited every time for last about, I would say, 5 times at least, because it is usually, unfortunately not this year, so interactive that it's unique for me to get the perspective of patients much better than any other way. So we're going to talk specifically, and I'm going to try to simplify management of myelofibrosis as it is, in my view, in 2021. So let's go to the next slide. Okay, so we are talking about two types of the myelofibrosis patients. What I divided here is on the left side, early pre-fibrotic myelofibrosis. This is the myelofibrosis that start to exist as a full-fledged entity since 2016 by World Health Organization, who put up the classification of bone marrow diseases. And early pre-fibrotic myelofibrosis doesn't have much of fibers. We would typically grade the fibers in the bone marrow from scale of 0 to 3. 0 and 1, so no fibers or minimal fibers, that would be early prefibrotic myelofibrosis. If there is advanced fibrosis there, grade 2 or 3 on a scale from 0 to 3, then we are talking about overt primary myelofibrosis. This is what we usually talk about in the past. And I'm going to spend the next two slides on the early prefibrotic myelofibrosis because it's different management than the fibrotic overt myelofibrosis. So you already see on the left side, early prefibrotic myelofibrosis focuses usually on the vascular events, increased risk of blood clotting, and management is typically as patients with essential thrombocythemia. And I will explain why. The life expectancy is typically on average about 15 years. Then we will talk about fibrotic myelofibrosis for the most of the presentation, which comes with progressive constitutional symptoms. These are night sweating, low-grade fevers, itching, and others. Progressive increase in organs, liver and spleen, and progressive cytopenia, meaning lowering of the blood cell count, and in some patients, transformation to acute myeloid leukemia and premature death within 5 to 7 years on average. Let's go to the next slide. Talking about pre-fibrotic early stage myelofibrosis, this is not so aggressive neoplasm of the bone marrow. How did we come up to recognize it? This is one of the major papers led by Dr. Barboui some years ago, 10 years ago, saying that some patients that we were historically considering as having essential thrombocythemia, that means high platelets, right? Everything else normal, may not be patients with essential thrombocythemia. They may have actually early stage myelofibrosis. So they were carved out of the ET patients. This is shown on the left side. This is overall survival of the patients that have pure, clear essential thrombocythemia in red line, which is normal, close to normal for a typical patient who is diagnosed in mid-60s. And you see the other line, early prefibrotic myelofibrosis on the left side, which says a median survival of 15 years, somewhat shorter than normal, but it's 15 years. And what's the risk of progression to fibrotic myelofibrosis or acute myeloid leukemia? That is on the right side. We see transformation to overt fibrotic myelofibrosis for prefibrotic myelofibrosis in right upper corner is 15% after 15 years. I'm talking about 15 all the time. 15 years average survival, 15% progression to fibrotic myelofibrosis after 15 years, and progression to acute myeloid leukemia, it's in the right lower part, is 10% after 15 years. So great majority of patients are actually presenting with high platelets and have a very good outcome otherwise. Let's go to the next slide. And therefore, the guidelines that were actually clarified for all of us is that, yes, most of the patients mimic patients with essential thrombocythemia, and they should be treated as patients with essential thrombocythemia, worrying about bleeding and thrombosis. And only minority, and some over time, can develop that symptoms of fibrosis with the shorter life expectancy. That is progression toward fibrotic myelofibrosis. So that distinction between prefibrotic and fibrotic myelofibrosis is important, because I get patients here to come with early stage myelofibrosis, prefibrotic myelofibrosis, and say, I'm going to die in 5 years. I need a transplant. Not so. It's not so aggressive. But let's go next slide to fibrotic myelofibrosis. Fibrotic myelofibrosis requires assessment of the life expectancy. And this is not to go through in detail. This is something that anybody can print and use, because these are some of classic, and you have in upper part of the slide, classic 3 prognostic scoring systems that utilize different prognostic factors. This is all for you to print and share. And the point I'm going to make here is that the goal of any of these prognostic scoring systems is to identify patients that have a life expectancy less than 5 years. Again, that applies to fibrotic myelofibrosis patients more or less. And you can see in a table below that intermediate 2 or high risk by any of these prognostic scoring systems are those that have a life expectancy less than 5 years. If the life expectancy by prognostic scoring system of your choice is less than 5 years, then it's reasonable to suggest the transplant. Let's go to the next slide. I'm always asked which prognostic scoring system should I use. There is no clear answer. Depends, do you have all the factors that need to be put in a prognostic scoring system. And of course, there is a variability among them. For example, if you look in a blue first bar on the left, this is International Prognostic Scoring System. And you look, for example, in the intermediate 2, this would be second from the top. When you have a patients in that group by IPSS, if you apply and you move to the bar in the middle, you apply DIPSS, many patients move. As you see, from the intermediate 2 to intermediate 1, 61% is de-escalated. So there is no perfect prognostic scoring system. There is no perfect prognostic scoring system. It is something that is relatively loose. Next. And now we have a molecular findings to include in these prognostic scoring systems. Everybody is aware, and that was very nice talk at the beginning of the day, about driver mutations, those mutations that are associated with biology of the disease activating the JAK-STAT pathway. This is JAK-STAT pathways, a pathway of different proteins, a cascade of proteins inside the bone marrow cells that lead to uncontrolled growth of the cells and inflammation that comes with the disease. In the top part of the slides are mutations that are driver mutations. This is calreticulin, CALR, JAK2, and MPL. And you see that presence of one or the other has different influence on the survival of the patients. And in the lower part of the slides, you have information about other mutations that many of us test for. These are not associated with the JAK-STAT pathway. They may be present. Some of them have influence on the outcome as well. So it's becoming complicated. And there are many new prognostic scoring systems. I'm not going to list them here because there is no perfect one, and many are very complicated, require you to go online and calculate this through the calculator that is available on specific websites. It is becoming difficult to do that, but unfortunately, all that precision is only for less than 10% of the patients that they get to the transplant. A lot of work with a good intent, but unfortunately, again, very few percentage of patients in totality really get to the transplant. Next. So once we are done with the prognostication, then we say, what's wrong? What do I do for the patients? And clinical needs are problems that we see in the patients. Then we say, what are we going to do about it? The clinical needs are on the left side. They're listed. And so anemia is present. Corticosteroids would be prednisone. Danazol, it's anabolic steroid. Erythropoietin is the growth factor that we all have in our body, and we can get it as injection under the skin. And there are some other anemia drugs. And you see here in red color those that are actually approved, right? Ruxolitinib and Fedratinib are JAK inhibitors that are approved based on their ability to counteract big spleen, I would say liver as well, and constitutional symptoms. And ruxolitinib on its label by FDA also says that it may prolong survival for a few years, which I will explain a little bit better in a minute. But you see that there are other problems that can happen. There is even a role for interferon or hydroxyurea in hyperproliferative early stage disease when the patients have very high blood cell count, like high platelets or high white cell count. And I'm going to talk about accelerated and blastic phase. This is when the blasts go up and patients go to acute myeloid leukemia. This is next to the last on the table, and therapy with what is called hypomethylating agents. I'm going to explain that in a second. Next slide. So I'm going to first talk about symptoms. That's why it was in purple color on a previous slide, because symptoms are present in great majority of the patients. And unfortunately, critique on our part, me as a doctor and our colleagues, we are trying very hard to objectivize this problem of a quality of life. However, the studies like this one from Germany, it's saying that many patients do not have questions asked, they do not project perhaps properly, or the doctor doesn't really understand well the problems with the quality of life. So many patients may still have symptoms that are not accounted for in everyday practice. Next slide. In that sense, we encourage everybody, and our United States and European guidelines encourage utility of this particular questionnaire, which can be printed from online source. If you go to NCCN, Nancy Charlie and Nancy NCCN guidelines, you can print the questionnaire and use it in everyday practice. I encourage this to everybody, doctors and patients, to utilize this questionnaire to objectivize the quality of life issue. Next. How good are JAK inhibitors? Ruxolitinib has been around for 10 years, and it was compared to best available therapy, that's its BAT, in a randomized study. Most of BAT, best available therapy, which was in the blue color on this slide, was hydroxyurea, right? So what I'm showing here is decrease in the spleen. You have horizontal line 0, that is the size of the spleen at the beginning, everything going down. Every vertical line is one patient. When it goes down, that's improvement. When it goes up above 0, that's worsening. So you see that the majority of the patients with ruxolitinib improve, only very small percentage does not. Unlike hydroxyurea, which is a mixed bag here. And so that's why JAK inhibitors and ruxolitinib is preferred for control of the splenomegaly, big spleen, big liver, and also improves the quality of life a lot. Next. Now, it has come to our attention over time, and this is one of the major studies that prove the point, that earlier intervention, you can say earlier based on a risk of dying. So if you are a really intermediate risk, low, intermediate, one risk, these are earlier stage of myelofibrosis patients, the earlier intervention matters in terms of a quality of response. This is a study in 2,200 patients in 26 countries, and patients were divided based on a risk of dying. And in red color are low risk, intermediate, one risk, so earlier stages, not so sick people. And the gray is intermediate 2, and the blue is high risk. Now remember those prognostic factors and the scores that I used before. What I'm showing here from left to right is the response in the spleen, how good the spleen response is. You see the red color is always better than any other. The less sick patients have ability to respond better because they receive higher dose of ruxolitinib. Next slide. And there is a correlation between the dose and the spleen response, which is on the left side. You see here, you have the bars that go from 0 to down. This is degree of a spleen response. The higher the dose, the better the spleen response. This is not so when we talk about symptomatic improvement, which is on the right side. On the right side, there is a lack of correlation between the dose and the symptomatic improvement. You have 10 milligrams BID. BID means twice a day. 10 milligrams twice a day is equally effective in controlling symptoms as a higher dose. So if you want to control the spleen, we want to maximize the dose. If you want to control only the symptoms, 10 milligrams twice a day is enough. So I say usually avoid starting with low dose. If you do start with low dose, escalate in a safe way to get the spleen as small as possible. Next slide. So there was one paper that summarized everything that I said in analysis of 400 patients from Italy, saying that influence of disease stage on quality of response is obvious. Time interval between the diagnosis and starting the therapy matters. Larger spleen or more of the symptoms matter. Anemia or thrombocytopenia that are already there matter. So earlier interventions, easier to manage patients, better response, and it may last longer. And the lower part of the slides talks about influence of ruxolitinib dose. Earlier disease patients, again, may tolerate higher dose, better spleen response. Better spleen response, I will show you that in a second, means actually more of a durable response. Let's go to the next slide. The problem with ruxolitinib is the anemia and thrombocytopenia. What I'm showing here on the left side is platelet count on the therapy. Red color are patients' platelet numbers when treated with ruxolitinib, otherwise is placebo. So with ruxolitinib, platelets goes down, red color on the left side, and you see hemoglobin, which is anemia, developing on therapy on the right side. But there is also a rebound in the hemoglobin because you can adjust the dose. You can add anemia drug to ruxolitinib, and two together may work, and that's why perhaps anemia improves in some patients. And there is a natural rebound in red blood cell count that I cannot really explain. So anemia, however, is the major problem. Let's go to the next slide. So I want to highlight this anemia issue because we expect from one drug to do wonders. There are limitations to what the drugs do. JAK inhibitors are good for the spleen and symptoms, not good for anemia. They may worsen it, as I show you. So typically, I would add anemia drug. EPO means erythropoietin level. That's that growth factor that we can measure in the blood of the patients. The measurements are seen here, 500 million international units. This is the cutoff for its use. If it's lower than that, you can use ESA. This is erythropoietin stimulating agents. If there is no response, then you go to danazol, anabolic steroid. Unfortunately, not much else you can do. Erythropoietin stimulating agents, danazol, maybe prednisone, thalidomide, I showed before, is a possibility. This has been like this for a while. No new drugs approved for anemia, but combinations matter. Next. Next slide, please. Okay, Jakarta is the study that led to approval of Fedratinib, another JAK inhibitor, in 2019. It is indicated for patients with myelofibrosis that have, and it goes by the risk of dying, unfortunately, I would say, intermediate to and high risk. But basically, it does what ruxolitinib does. You see it in a bold. I put Fedratinib 400 milligrams recommended dose. That's a starting dose for anybody. There is no adjustments for the platelets. And with that dose, you would have a 37% response rate by official definitions and 40% responses in the symptoms by official definitions. And that was compared to placebo. And in that setting, I would say Fedratinib is about the same for the spleen and symptoms as it comes to the official response criteria and the rates of the response. There is little difference in the safety, which is in lower part of the slide, and that is that one needs to measure thiamine level, which is vitamin B1. It's a vitamin that appears that Fedratinib interferes with when it comes to uptake of thiamine from the GI tract to the body. And lack of thiamine, which therefore you need to measure and supplement, may cause very, very rarely a central nervous system toxicity, which is called Wernicke encephalopathy. Easy to overcome or prevent by giving thiamine. So I do this in my own patients. The most common adverse reactions actually are diarrhea, nausea, and vomiting, because that is something perhaps more prominent with the Fedratinib than ruxolitinib, requiring in some patients anti-nausea medication. So you have another option here in a frontline setting, Fedratinib, a little bit different on the safety parameters than ruxolitinib. Next. Now let's talk about something else very briefly, and you will obviously recognize that I'm going to talk about the life expectancy. You see the patients when it came to me on the left side, on the right side, 7 years later, right? 7 years later. And remember, we don't eliminate disease with anybody. Next slide. So do patients really live longer? This is analysis of Medicare claim database in the United States presented by me last summer. We are looking at a very large number of patients in United States that are in Medicare database and whether they were given ruxolitinib or not. That's indirect way of having some information whether the therapy influenced the survival. Look at the curves on the right side. You have in green color ruxolitinib treated patients, in a blue color not treated with ruxolitinib. Of course, it can be because patients were too sick or they didn't have a means to afford it or some other reasons I can't explain. But observation is very powerful. So this life extension possibility still is questionable in many eyes, but the data is coming up like this saying, yes, it can do that. Why can this happen? Next slide. Because you can see on the left side, there is improvement in albumin on therapy. In red color is treated patients with ruxolitinib, in blue is placebo. On ruxolitinib, albumin, which is a protein in blood, goes up. Cholesterol goes up. You see on the right side, the body weight goes up. People can walk more, and body composition improves. Next slide. And this slide shows that perhaps I can just show you on the right side. This is the relationship between the quality of kidney function improvement and progression, basically, to make it simple. So what I'm saying is the body composition improves, the weight, the ability to walk, metabolism, and organ function improves, as is evidenced by the improvement in the kidney function. That's why with the control of the disease and signs of the disease, patients can live longer, on an average about 3 years. Next. And the spleen response appears to be the most important factor that would tell you how long the therapy will last and how patients will live, how long the patients will live. What I'm showing here is in the upper part of the slide, ruxolitinib, and below the ruxolitinib name are percentages decrease in a spleen size. And in the middle of the slide is a vertical line. Everything to the left is improvement. So the more the spleen reduces, the better the longevity or survival of the patients. That's why I'm trying to optimize the dose of ruxolitinib to get to the maximum safe dose, to get the spleen as small as possible, and I start earlier, not later in the life of the patients, to get this part done effectively to get people to live longer. Next slide. And then we ask the question, sorry, something happened with the slide, but the question is, what leads people to stop ruxolitinib? And you can see the circle, actually, perhaps good enough. Anemia appears to be the main problem. So remember, anemia is not contraindication. Earlier intervention matters when anemia is not so prominent. Combination with anemia drugs are advised, and trying to prevent people from stopping for something that we possibly can help them with, and that would be anemia. Next. Once you stop, what can you do? Fedratinib has been studied not only in a frontline setting in the same patients as ruxolitinib, also in patients that were previously treated with ruxolitinib. These are so-called ruxolitinib quote-unquote failure patients. Not to go through details here, but if you just go to the left lower part in a box, it says clinically meaningful reduction in splenomegaly and symptoms burden were seen in patients, and that is SVR. This is spleen volume reduction. 30% of the patients responded, and symptom response rate is 27%. So very valuable information to know. Fedratinib is active agent after ruxolitinib. It's not that you have a resistance to another drug. They're similar, they're not identical, and you can use fedratinib after ruxolitinib. Next slide. And then to finish up with the last slide, this is what happens if the blasts go up. Remember, blasts are baby cells in the bone marrow, and everybody can have a few blasts here and there in the blood as well, but then the blasts can go up. And if you look at the middle of this slide, you have MFAP. AP means accelerated phase. Blasts in the blood or bone marrow are 10 to 19%. Normal in the bone marrow is less than 5. In blood should be 0, but again, many patients have some. If they go to 10 to 19, we call this AP, accelerated phase. Below that is BP, blastic phase, or AML. This is 20% or more. These days, we put them together in terms of the therapy approach. You see the therapy approach is on the right side. If there is a transplant, go with the transplant. But before that, try to treat patients with HMA, hypomethylation agents. These are agents that are approved for therapy of myelodysplastic syndrome and acute myeloid leukemia. Different exist, Videsa and Dacogen. Hypomethylation agents, or HMAs, given usually IV over 5 days every month. They can supplement intensive chemotherapy. They are actually suggested as a front line. Intensive chemotherapy has less and less room. You can still continue treating patients or taking ruxolitinib to control spleen and symptoms, but ruxolitinib or any other JAK inhibitors do not prevent progression to acute myeloid leukemia. So if the blasts go up, I would add HMA, Videsa, for example, to ruxolitinib and try to get patients to the transplant. Next slide. And I thank you so much. I hope I covered a lot in a relatively simple way. I'm looking forward to discussion when it comes time. Thank you.
Thank you, Serge.